her vacation. So hope everybody's having a good time. So again, couple things to keep in mind today. If you're out in the next few days, if you're riding, please make sure you drink lots of water. It's going to be a sweat box out there. So the other thing is I'm finally trying to get into Platinum to look at your calls. I sent Tacey an email and I can't find any of her calls from 360. And I'm betting it's going to be the same for everybody. So were you able to download the PDFs? Okay, so if you can download the PDFs from 360, I can find everything that starts, I think, starting in May. But for whatever reason, when I search by name and by date, nothing comes up for me outside of what you're actually doing currently. So I'm hoping to begin working on that later today. Dylan.
If I've already emailed you the 360 ones from way back.
No, don't send them to me again.
Okay.
Yeah, you're good. James.
Are you saying the stuff we started for our capstone you haven't been getting, so you want us to PDF?
No. 360. Oh. 360, back in the spring. So, again, just download those into a PDF, and especially what I'm interested in is your narratives that I'm able to go in and look, and then I'll run your SMCs. Talk with Steve today. If you are needing specific skills or specific patient contacts, things like out of hospital births, please contact him about setting up a simulation. He said he was going to probably set up a couple of days that'll be set days between now and the end of the summer semester for you to be able to come in and do that. But I also suspect that he'll be willing to work with you within reason based on your schedule and his schedule. I don't want you to do things like IVs and routine medication administrations because you should be getting all of those and documenting all of those within your capstones. But things that are kind of way out there, if you've not had a cardiac arrest, we can simulate a cardiac arrest for you. Most of the time, you'll get at least one. I think you have to have two for your SMC. But again, as far as that goes, and in particular, PEDS and OB, things along that line. So the plan today is that we're going to do, for the first hour, we're going to do a review on EMS operations. And then you're going to come in and you're going to take your EMS ops exam for today. Skylar, are you able to hang out and do your, okay, thank you. Yes.
How many questions about home meds do you think would be common?
On what?
The home medication that you give us.
I think I've got 10 questions on this, okay? And as far as the home medications, that's the only question that I'm giving you that I will give you partial credit for. So the ones you get right, you'll get credit for. Everything else, I'm trying to simulate very similar to what you're going to see on the registry. It's an all or none principle. So any other questions about anything going on right now? So think about it this way. You're like 5 weeks out from being approved to test. If your grade right now is at 82 or below, you need to make an appointment to see me. Okay. Some of you are doing great. Some of you are giving me a little bit of heartburn. So again, remember, you got to hit that 80 percentile to finish this semester up and be able to go and pass 362 and to be approved to take your registry. The other thing I would tell you is, and we generally do not have a problem with you guys as paramedic students, take that exam as soon as you can. Take it as soon as you can. If you've passed this course and you've passed all your other courses, don't sit and say, I need to study a little bit more. You're ready. You're ready, okay? So, any questions? All right, cool. Let's get into this. And Tacey, we're going to start over here with you for the first one. Let me do this. There we go. So you got a 54-year-old female who's trapped in a car and complains of chest pain. You're unable to open the door and the fire department is unable to get their extrication tools to work. What should you do? A, Wait 30 minutes for the replacement tools to arrive. B, break the window farthest from her to gain access. C, use the extrication tools without power. Or D, use a handsaw to cut the narrowest part of the frame to gain access. Now, which one of those do you feel like is the best answer? Yeah, so what we're going to do is we're going to break. How many Tacy's do we have in here? I heard one with a really deep voice. Anyway, keep in mind that, again, within your EMS ops section, we're looking at things such as very, very simple extrication. We're looking at medical, legal, ethical, and incident command. And so in this particular situation, you got a lady who's in a car. She's having chest pain. That in and of itself makes her unstable. And so we got to get somebody into that car. So you're going to break a window and you're going to put somebody in there as quickly as you possibly can. Okay. All right. Holly. 13-year-old unconscious male and a 15-year-old conscious female were in a motor vehicle collision. What should you do? A, wait to assist the 13-year-old until a parent arrives. B, assess and treat only after a police officer gives you permission. C, treat the 13-year-old under implied consent. Or D, wait to treat both of the patients until you obtain parental consent. C is correct. Now let's talk a little bit about consent here, okay? So we have explicit and we have implied. Explicit consent is literally a patient is able to verbally or by their actions give you permission to treat them. So for example, what I mean is by their actions is let's say that Holly says, well, Bill, I need to start an IV on you. Is that okay? And I either nod my head or I do exactly what Skylar did is I extend my arm out. So you're getting explicit permission in that situation. Implied consent is literally saying, and the courts have held this up, saying that you will treat the patient how you think that a normal, rational person under similar circumstances would want to be treated. And this falls into the exact same line when we're dealing with minors, okay? So when we're dealing with somebody that cannot get permission from their parent, from their guardian, implied consent says a normal, rational parent would want that person taken care of. Here is your best protection regarding consent. And most of the time, we don't have issues where paramedics are found guilty of ignoring consent. If you're doing legitimately what is in the best interest of the patient, most of the time you will be protected should it go into legal activity, okay? And that's going to be the key. Caden, this one's yours. You've been assigned to triage at an MCI. Your patient is bleeding from a cut on his head, respiration of 22, pulse of 100 radially, and he keeps asking, what happened? What priority should be assigned to this patient? Yellow, green, red, or black?
B.
Which one?
B.
B, you're going to give him a B? Tell me why green before I show you the right answer.
He's just bleeding from a cut on his head. I would assume the bleeding's minimum. Respiratory rate's 22 and his pulse is 100. He's just kind of anxious about like what's happening and he's breathing rapidly. He's just kind of like, oh my God, what happened? His airway's 8, I would assume. So.
Okay. So you're really, really close, but we'd actually classify this guy as yellow. Let's see why. Remember, say it again. So he's got a head injury and he is confused, okay? And so everything that you said about his airway being open, yeah, he's talking. He's got a good patent airway. He's got 100 pulse, okay? So that tells us he's perfusing pretty well for now. Excellent, for now. And so the key thing that we're going to do here is we can't put him in green yet, and he definitely doesn't qualify as immediate, okay? So we're going to put him in that yellow category of where we're going to put somebody in and make sure that they watch him closely to see if his confusion now continues to get worse or get better. Now, here's a key thing to remember about head injury patients, okay? Head injury patients and seizure patients will do just this. As they're progressing through the aftermath of the injury or the seizure, they will ask you over and over and over, what happened? What happened? What happened? And they will try your patience because every few minutes they'll ask you the same question, even though you have already explained to them what has happened. But that's a key finding as to if they continue to ask you what happened, they're not getting enough oxygen to their brain. In this situation, like I said, he's breathing fine. He's got a good pulse. He's awake. He's just not alert. He's confused. So in this situation with a mechanism of injury, we would classify this dude as yellow and just kind of keep an eye on him there. So, James, what is the term used to describe the obligation you have to render assistance to a patient? Good Samaritan law, duty to act, standing order, or advance directive? Shh, James. There's Ollie's and or Tacey's and too many James.
I'm gonna say
Okay, duty to act. So let's talk about this for just a little bit. Duty to act says that once you have been dispatched to a call, or if you are off duty and you establish care with a patient, now you have a duty to act. What about, let's say that you're just driving down the road, you see a wreck, you see somebody laying over there, do you have a duty to act to stop? Not at all. Very good. Yeah. So not at all. You may have an ethical duty to act, but that's going to be between you and your own ethics, okay? In this particular situation, keep in mind that once you have established that duty to act, you are tied to that patient. Now, let me ask you a question. Let's say that you are dispatched to a call, and on the way to the call, you run into another, say, wreck. What do you do in that situation? Say it again. So you would, by your own duty. Okay, so you're going to call your dispatch and do what? Are you going to stay at the one you ran into, or are you going to go on to the first one, or to the one you were dispatched? Okay. Anything else?
then you call for another truck to respond to that.
Okay. Or fire. Okay, so in this particular situation, there's a lot of gray areas, but again, this is where you kind of focus in on what's your best for your patient. For the most part, if you've got a critical patient that's right there in front of you, I would probably, and I'm not a lawyer and I don't play one on television, but I would probably stay with that particular patient because it's kind of like, I know this patient is critical. I don't even know if we've got a patient over here. So you would most definitely in that situation try to take care of the patient that is the most critical. What about if you've got a patient in the back of your truck, you're transported to the hospital, and now you run into another call? Now what do you do? Is that Caden? You're going to call dispatch, but what will you do? Are you going to stop and you're going to help take care of the patient now that you come into contact with? Say it again.
You're already like assigned to that patient. You got to take care of the patient.
Okay. What's the variable in this particular scenario?
How many trucks you have?
That's going to be definitely okay. So if everybody's tied up, that's important too. But what else? There you go. Say it again, Tacey. How critical? Who? Which patient? Bingo. Both patients. Okay. So the question is going to be, are you taking a patient, let's say you're taking a patient to the hospital or to dialysis. They're stable. You're a medic. You're riding in the back. It's your turn to ride in the back. You've got an EMT partner. There's absolutely, positively nothing wrong with telling your EMT partner, stay with this patient while I go up and assess the other patient. Okay? Now, it gets much more murky if you've got a critical patient in the back and you roll up on another accident. If your patient is critical in the back, I would tell you got to focus on the patient that you have and then request another unit to come to that particular scene. Okay? All right? This is one of those situations of where literally it's the practice or the art of medicine of where I wish I could give you a hard and fast rule of what to do, but you got to do what's best for the current patient you're with as well as a potential patient. Okay? Skylar.
Yes.
43-year-old male complains of stiff neck, persistent cough, and fever for the past week. He states he's been in and out of homeless shelters for the past 5 months. What should you do? Use gloves, gown, and a HEPA mask. B, put eye protection and a surgical mask on. C, apply oxygen by non-rebreather mask. Or D, have the patient wear a HEPA mask.
I think I might go with A.
Good. Very good. So, again, in this situation, a little bit of a medical review here. Skylar, what do you think this guy is suffering from?
Bacterial.
Absolutely. So he's probably got meningitis, and it's primarily going to be because of that stiff neck that's going to come in play here. Understand that meningitis shows up in nursing homes. It shows up in prisons. It shows up in homeless shelters. And it shows up in college dorms because you have large groups of people congregated into a relatively small area. So in this particular situation, what you're going to do is you want to use the gloves, the gown, and the HEPA mask. If this dude's got a persistent cough, he's probably also going to be having some respiratory distress. If you remember back in the bad old days of COVID, if you wore a HEPA mask, you remember how hard it was to breathe through that. You don't want to put that on your patient, okay? If your patient is in this situation, let's say instead of a stiff neck, let's say that we say that he's got night sweats. What are you thinking as far as a diagnosis now? Anybody? Nope.
He's got night sweats on top of it.
Yep. Say it again.
With the stiff
No stiff neck, but in exchange for the stiff neck. TB. Okay, so we're thinking about tuberculosis here. So if this, what did I miss? So, she said it too. My ears are so plugged up and I can't hear anyway. So yell at me, please. So again, in this situation, if this dude is having respiratory distress, we can put a nasal cannula on him. We can put a non-rebreather mask on him if we need to. And then we would put a surgical mask over top of that to help try to filter out some of that stuff. But you don't want to take stuff home to your family, okay? Dylan, 26-year-old female jumped from the second floor of the house. She states that she was getting away from her abusive husband. What should you do? A, check for bilateral ankle fractures. B, assess for compression injury to the spine. C, determine if the scene is safe. Or D, obtain a set of vital signs. C is correct. Now, this question is actually based off a real-life scenario. If you've ever been up on Richmond Road, there's a relatively new elementary school there that is named for a firefighter who was killed on the line of duty, responding to something similar to this particular scenario here. In that situation, there was an abusive situation. The firefighter and her partner rolled up on the scene, got out of the truck, and the husband was still in the house with a firearm and shot and killed the firefighter. In this particular situation, you have to remember this lady was in fear for her life to the degree that she was willing to jump out of a second floor window. So she felt that her husband was serious about causing her harm. And in that situation, you have no idea as to whether the husband's still in there, what type of firearm he has. And so if you're close enough to where you're actually talking with a patient, at that point in time, grab a patient, move to your truck, and move a good distance away from the scene. And then once you get where it's safe, then you can go ahead and begin treating your patient. Okay, good, Dylan. Chris, 26-year-old female is trapped after a motor vehicle collision. The driver's side window was broken. The airbags did not deploy, and the car came to rest on a steep, grassy slope. When approaching her, what should you do? A, have her sit perfectly still. B, pop the hood, disconnect the battery. C, cut out the windshield to gain access. Or D, place cribbing under the tires.
I'm gonna say A.
Good. I use these questions to tutor a lot of students around the country, and the vast majority of them will go with D. Now, first of all, let's look and see why D is not a good answer. Why is D wrong? Well, first of all, what is cribbing? For anybody that may not know, what's cribbing?
Something it just folds up under the tires. It's like triangles.
Yeah, so it's made out of different material. It's the most rudimentary form. It's blocks usually of like 4x4 pieces of wood. Colin?
I was just saying, if you go to crib a car, they might start rolling towards you.
Okay, we don't crib under the tires. Yeah, very, very good. We crib under the frame where you've got friction that will hold it and keep it from moving. So if you crib under the tires, you simply just putting something under the tires, those tires are still going to be able to roll. So again, in this particular situation, from a registry test perspective, popping the hood to disconnect the battery is always still going to be a good option because, again, you don't want to get in there and have an airbag deploy and potentially cause you some really severe damage. We may have to cut the windshield out to gain access, but there's nothing that indicates that we're going to have to, especially from the fact that it says the driver's side window is broken. But as you're looking at this, and again, this is from a registry test taking perspective, you got to understand a little bit about the physics of motor vehicle collisions. The car's on a steep, grassy slope. We want her to sit perfectly still because we don't want her moving around and make the car move. So we're looking at the thing that we're going to do absolutely first. Okay, good, Chris. Colin, this one's yours. When completing the narrative portion of your pre-hospital care report, the O in SOAP stands for operation, observation, objection, or objective. D is correct. So SOAP is just a simple mnemonic, stands for S is subjective, O is objective, A is assessment, and P is your plan of treatment. It's one of the different ways in which you can document. Okay, chart is another one, and there are several out there. Depending upon what your agency utilizes, make sure that you follow what they want you to do as far as your documentation. Excellent. Sean, what is the degree of skill and judgment that would be expected of a similarly trained, reasonable paramedic acting under similar circumstances referred to as standard of care, scope of practice, professional standard, or paramedic code? So let's talk about these, because standard of care and scope of practice, we often get confused. Okay, bless you. Scope of practice is what you are legally authorized to do. Okay? You're legally authorized under Kentucky state law to do finger teeth, to do surgical airways, to put needles in people's chests. So that's what you're able to do. You are not legally authorized to put in chest tubes yet. It's coming. Trust me. It will be here probably within about 5 years of today. Because again, if you can put a finger in, there's no reason why you can't put a tube in as well. So again, your scope of practice is what you're allowed to do. Standard of care is how well do you do it. And the really big extreme that I like to use to illustrate this is, let's go to a BLS skill and talk about traction splints. You can put a traction splint on. Traction splint is a good splint, but if you put it on upside down, bad things happen. Okay, so the fact that you can put a traction splint on, that's within your scope of practice. The fact that you put it on upside down means you violated your standard of care. And basically, what happens if it goes into a court of law, what will happen is that they'll bring in another paramedic and simply say, Mr. and Ms. Paramedic, tell me what you would have done under these circumstances as well. And so that's what your standard of care will be based upon. What would a paramedic that has similar training, not experience, most of the time an expert witness, and this may be something as you get more experience, probably you're going to want about 10 years of experience, you may want to consider kind of going into as putting your expertise together. But a similar trained, reasonable paramedic under similar circumstances, what would he or she have done? Okay, Jack. What's the most common route of hazardous materials exposure? Absorption, injection, ingestion, or inhalation? D is correct. Most of the time when we are exposed to some type of hazmat material, it's because it's in the air. It's finely dispersed, it's widely dispersed, and we breathe it in. Okay? All right, Matt, this one's yours. What is limiting the number of people or resources you are supervising known as? This is an incident command question. Command and control, unity of command, unified command, or span of control? So in this one, actually, it's called span of control. Now, again, what we're looking at here, let's talk a little bit about ICS. Okay, ICS has arose back in the late 80s, early 90s from all the massive fires that Colorado generally has. Right now, the massive fires are in southern Utah. But this ICS system has been evolving into something that is used nationwide. It's used within the military. And so it's basically to get everybody on the same sheet of music and doing the same thing. One of the things that we look at here is called span of control. And a span of control is that you start out up here at the top with your incident commander, and then you have your different sections, and then under those sections you have people that are overlooking people who are actually doing the on-ground work. Span of control says that any one person can supervise effectively 5 to 7 people within their group. And the whole purpose of that is, number one, to, in particular, remember this arose during wildfires, is to, number one, know where your people are at all times, and number two, to be able to track equipment and expenses so that you can submit to the government for reimbursement after the incident is over. So span of control is generally saying how many people that you're able to effectively and adequately supervise at any one time, and that number is going to be 5 to 7. Tacey, the all hazards approach to disaster planning involves A, tabletop exercises that focus on worst case scenarios, B, communicating with federal officials regarding terrorist activity, C, protecting critical infrastructure from large scale disasters, or D, conducting comprehensive pre-planning for all types of disasters. D is correct. Now, basically what we're looking at here with an all hazards approach is that we look at what are the most common disasters that we would have in a particular area. In Kentucky, flooding is a very, very common type, obviously, as we've seen. It's very uncommon for flooding to have hit central Kentucky the way that it just did.
We had flooding over the weekend, and Madison County got called to an incident right near Main Street over there, and one of my coworkers that was lost was the neighbor of the person who was trapped.
Oh, really? Was this the two people that were trapped in the basement? Yeah. So that you know, we get storms through here, but typically Central Kentucky doesn't deal with a huge amount of flooding. Most of the time, the flooding is over in Eastern Kentucky because everything is kind of like this. The mountains are like this, and everything runs into just a few streams, and then those streams expand out. However, the lessons that different responders learn from those floods in Eastern Kentucky, they implemented here in Central Kentucky. The other thing to keep in mind is that you learn lessons from different disasters that you would go in and be able to apply to another one. In Kentucky, we have tornadoes, we have ice storms, and we have floods. And so there's many things that we see within that particular area. In the southern part of the United States, you have a lot of hurricanes. Hurricanes you can kind of prepare for, you can predict them, but again, they would see those things that are coming into play. With wildfires, you can see very similar things that you can learn from wildfires as opposed to like tornadoes. And so the all hazards approach is literally we're going to pick and we're going to be able to learn things from these things that will allow us to deal with any type of disaster that comes along. Holly. An attack on an abortion clinic would most likely be carried out by A, issue-oriented group, B, technology terrorist, C, violent religious group, or D, extremist political group.
Golly.
Good question.
That is a very good question.
Now, watch what she's doing. She's taking her time. Now, guys, when you take your, I wish you would do this with my exams. Some of y'all are rushing through these exams. Take your time, please. When you take your registry exam, they're not going to give you a refund for the time that you don't use. Take your time. What she's doing is really, really good. So, now, hurry up, Holly. So, it's actually a violent religious group, okay? Most of the time, again, when we're talking about abortion, we're talking about religious extremes on the belief. It's okay what you believe or don't believe about abortion, so that's not the whole purpose of what we're talking about here. But again, most of the time there's an element of an extreme religious movement. Okay.
Couldn't C and D go?
Absolutely. And so, again, I just have not had time to edit to make this different. So if you'd have picked D, I would have told you that you were exactly right, because abortion is most definitely a political hot topic as well. So I agree 100% with you, Caden. All right, Kate, because I agree with you, this one's yours. At a mass gathering, several hundred people suddenly began to experience severe salivation, lacrimation, urination, and vomiting. What should you do? A, set up a command post and ensure scene safety. B, alert the Center for Disease Control. C, contact the Department of Homeland Security. Or D, evacuate all of the patients from the premises. A is correct. Good job. Okay, so let's take a look here. First of all, based on the patient's symptoms, what are they suffering from? Outstanding. Good job. Okay. So they're suffering from sludge. Okay. Salivation, lacrimation, urination, defecation, and gastric emesis. And then M on the end is meiosis. Okay. In this particular situation, what you're going to want to do is, first of all, you're going to make sure that you're not exposed, because you got all these people, several hundred of them got symptoms. So we definitely got something weird that's going on. And now what you want to do is you want to make sure, number one, that you don't become a victim as well. We're not going to alert the Center for Disease Control because this is most likely going to be some type of a criminal action. If CDC needs to be notified, that's going to come from your health department, not from you as the responder. Similar thing with item C or distractor C. That's going to come from your law enforcement. That's going to go to the Homeland Security. And most likely they are going to be involved. D is not a good thing because what the last thing we want to do until we know what we're dealing with is we don't want to move the emergency from here and disperse it around in a very, very wide area. Something that happened, I saw in the news last evening, and I kind of posted about this while I was up in Yellowstone, and I've shared this with you before. I realize I don't look it now, but in my younger days, I used to do lots and lots of backpacking, including out there. And I would carry bear spray because you guys have real bears out there. But I saw these really well-dressed people with brand new hiking boots that didn't have any dirt on them and name brand stuff, and they were carrying their bear spray, but they were inside the lodge. It's kind of like, there's no bears in here, okay? Just relax. So I was very concerned about an accidental discharge, but apparently somewhere up in New York, somebody discharged bear spray into the air conditioning system and caused an MCI. So at one of the hotels up there. So it's kind of like, yeah, it's just stupid people. So, all right, Caden, good. James, as an emergency vehicle operator, to ensure your vehicle is prepared for service at the beginning of your shift, you should first ensure that A, the exterior of the ambulance is washed. B, there's enough linen on board for several calls. C, all oxygen cylinders are full. Or D, no warning lights indicate a problem with oil pressure. Good. Very good. Okay. So many times I'll have students that will bite on C. Your oxygen does not have to be full. It just has to be above what your agency's minimum levels are. Yes.
Well, it's also the main thing that decided that's difficult with the
Well, very good point. Excellent point. As far as you're having enough linen on board, that's part of getting your vehicle prepared to go out. Now, again, you can run calls without linen. Okay. Now, you definitely want to have enough blankets in case you've got a patient that has hypotension or is trauma, because we've got to keep them warm. As far as your oxygen cylinders being full, it's just got to be what your minimum level is. When I worked in Georgia, our minimum level was at 500 psi. We changed them out. So that will all be dependent upon what your own agency's policies are. But again, if you've got warning lights, especially that you got oil pressure, you got to take that truck out of service, because there's a possibility you're either not going to be able to get to your patient, or you're not going to be able to get your patient to definitive care. So very good. Scott, at the scene of a multiple vehicle accident, what should you do first? A, establish incident command. B, start triage. C, set up a command post. Or D, treat the first patient that you see.
Hey,
A is correct. Now, in many situations, what we do is, in establishing incident command, it's a very informal type of thing. Basically, what it says is everything's going to run through one person, okay? You may have heard the old saying, you got too many chiefs and not enough Indians, okay? And in that situation, it's kind of like everybody wants to give commands, and that it just simply runs into a massive, massive level of confusion. So setting up incident command is going to go to the first person who gets on the scene. Now, you may hand that off to somebody else once they get there that is of higher rank than you. Now, incident command does not necessarily have to be a paramedic. Your incident command, as long as everybody understands the ICS system, your incident command can easily be operated by an EMT. And literally, that person's responsibility is to get the information that they can, relay it to dispatch, so that dispatch can send out those additional resources that we talk about in our little Scene Safe BSI dance. Yes.
Have you ever been involved in any emergencies where conflicts about that has occurred potentially?
It's really quite interesting. I have been involved in several problems. When I worked in Georgia, we had issues between us. We were a hospital-based EMS and the city fire department, but that always happened up here with the upper brass. Once you got out there on the scene and you were actually working, the people that actually do the real work seem to get along pretty well. And literally, most of the time, what's going to happen is that if you got a sick patient, they're going to look to you as the paramedic. Okay, and so it is rare that we run into some problems on the thing. Now, occasionally, you will see people who will have medics and law enforcement most of the time, or fire officers and law enforcement, where you get into this match of you're going to do this. Understand that ultimately speaking, the control of the scene goes to the men and women who wear the badge and carry the gun. Okay, so you got to kind of keep in mind. But those are rare. Those are really, really rare. Good question, Chris. Which sector, another ICS question, which sector coordinates operations with the staging officer and routes patients to the hospital? Triage, command, transportation, or communications? Again, I appreciate you taking your time. This is good.
It's triage.
So in this situation, it's actually transportation. So let's think about this, okay? Now, remember, triage's responsibility is to do no treating whatsoever. Triage just simply goes in through and goes red, red, black, green, yellow, red, and that's all they do. They tag these people and they move on, okay? Command is done by the person who has the radio, who stays at the ambulance, okay? Now, here's the thing you got to remember. With transportation and triage, you will work closely together. Transportation's responsibility is to determine, number one, where is the most appropriate hospital for this patient to go to. In a disaster, that may be as far as an hour away. The last thing we want to do, so for example, several years ago, there was a plane crash out of Bluegrass Airport. Unfortunately, there was only one survivor on that, so there was no possibility of UK being the trauma center in this area being overwhelmed. But let's say that we're dealing with a plane that goes down and there's 100 people on there. You're going to send patients to Louisville. You're going to send patients to Cincinnati. You're going to send, obviously, to Lexington. You're probably going to send some over to Clark Regional. Probably going to send some over to Georgetown. The severity of the patient determines where they're going to go so that we don't have any one hospital that just completely gets overwhelmed. Second thing that transportation does is that you need to try to do your best to track what patient goes to where. Now, in a disaster situation, it's rare that you're going to have patients' names and identifying information. That's where our triage tags come into play. And so literally what you're going to do is you're going to have patient 268442A. Oh, well, that patient went to UK. And you've got this patient that went over to Georgetown. And so you're able to realize where those patients went so that if authorities need to talk to them, they can, but just as important, so that their families can be reunited with them as well. So in this particular situation, the transportation is going to decide where they're going to go and track that whole information. Okay? Colin. You're the first ambulance to arrive on the scene of an overturned school bus on a limited access highway. You see several people on the bus. You should first, A, begin triage, B, request a helicopter to respond to the scene, C, set up a staging area, or D, establish command. Yeah, this is going to be one of the hardest things that you will ever have to do. I based this question on another real life incident that happened down in Chattanooga several years ago. There was a school bus that, for whatever reason, I don't exactly remember, but the driver lost control of it, crashed into a tree, and there were a lot of kids who were really, really hurt on this. Most of the time with school buses, they're built like tanks. So most of the time, the kids on the bus are going to be banged up, but they're not going to be critical. In this situation, there were some really, really priority people on there. One of the hardest things that's going to be for you to do is to not get bogged down in treating patients, even triaging patients. This is one of the reasons why I said that if you're working with an EMT partner, let your EMT partner go out and begin to do triage, because you're going to need a lot more resources than what you and your partner currently have. If you get tied up taking care of one patient, 2 or 3 patients over here that were viable may die because of that. Okay, so it's really, really hard. In essence, and I don't say this lightly, but you're kind of playing like God. You're deciding, I'm not going to do anything because this is for the greater good. This is a good registry type question because, again, you've got the scenario, and the very end of it, I want to remind you, is anytime you see those words, you should, or you should first, or you should next, based on where you're at in the scenario, what are you going to do immediately next? So in this situation, Colin was right. You're going to establish command. Sean. At the scene of a car crash at night on a rural limited access highway, you've been directed to set up a helicopter landing zone. You should ensure the landing zone is A, at least a quarter of a mile away from the crash scene, B, uphill from the crash site, C, 125 feet by 125 feet, or D, well lit with upward facing lights. Which one? D? So I said it's going to be C. Now let's see why D is not the right answer. Okay. Do you want lights going up towards the helicopter? No. Okay. Because if we blind the pilot, really bad things can happen. Okay. So we do want it well lit. Okay. But we want the lights to shine down onto the ground. At night, your landing zone should be 125 feet by 125 feet at a minimum. Okay, at a minimum. That gives the pilot a larger area in which to come and survey and see for any potential obstacles. It doesn't, a quarter of a mile away from the crash scene, that may be where you have to set up your LZ, but it's not always required. Okay. If you're landing on the interstate, most of the time it's like 100 and so feet. During the day, it's actually 100 feet that you can go with. As far as the LZ, and generally you want it far enough so that when the helicopter comes in, the prop wash is not going to spray everybody with debris, gravels and stuff who are still working with a patient. We definitely don't want it uphill from the crash site because, again, when the helicopter comes down, if they have to do kind of a skid landing, that's going to put the overhead prop much, much closer to people who are trying to get in. So in that particular situation, on this one, particularly at night, we want it to be a fairly large area. Okay, Jack. I don't like this one. Let's go with this. Here we go. Which of the following operational reasons warrant the use of a helicopter transport from the scene to a medical facility? The distance to the medical facility is 15 minutes away. B, the patient is in cardiac arrest. C, the patient is located in a remote area. Or D, the patient may go into shock shortly. C is correct. Now let's talk a little bit about transport by helicopter. One of the things I really, really appreciate about Massachusetts County is that they do not use helicopters very much here. Okay. Most of the time, if you have severe trauma on the interstate, your ground ambulance is going to, unless there is extended extrication, you're going to get your patient to UK quicker than waiting for a helicopter. Now, if they've got some people that are in the backcountry, that's a little bit different. If you got an extrication or a delay, that's also a little bit different as well. So I want you to understand helicopter is a tool as long as it is used appropriately. In my opinion, helicopters nationwide are probably overused, which means increased danger for everybody involved. And when you're talking about helicopter transport, you're looking at about 50 grand to start off with. Okay. So again, you want to use the helicopter for the most appropriate. In this situation, if the patient is located in a remote area, we know that we've got some rescue teams that use helicopter over in the gorge. And so that's most definitely going to be appropriate, especially if they go in and they hoist a patient out so that they can get them into that situation. 15 minutes away, you'll get there quicker by ground. The patient may go into shock shortly. That may warrant a helicopter, but again, it may not, depending upon your distance away. And if your patient's in cardiac arrest, they're not going to take the patient because you just don't have enough room to adequately work a cardiac arrest in a helicopter. Now, that doesn't mean that they're not going to work an arrest if it starts after the helicopter lifts off. But typically, what they are not going to do is if you got a patient in cardiac arrest, they're not going to accept the patient because they're not going to do anything different for the most part than what you're going to be able to do by ground for a cardiac arrest. And in the back of your truck, you'll have a lot more room. Okay. So we've been going at this for about an hour now. Do you have any questions on EMS operations? We're going to take a little bit of a break. I'm going to set up your exam, and I'm going to have you to be able to go in and take your exam. But any questions as far as ICS, EMS ops, medical, legal, or anything along that line that we need to review before we do your exam this morning? All right, hearing none, let's take 10 minutes.